Good morning, everyone. Our today's lecture is on nocturnal enuresis, that is bedwetting. So basically, bedwetting is a involuntary urination during sleep. It occurs in children over the age of 5 to 6 years, and at this age we expect that the child has developed bladder control. So basically, bedwetting is involuntary urination during sleep in children over 5 to 6 years at the age at which we expect that the child has developed bladder control, or it is defined as normal and complete evacuation of the bladder but at the wrong place and time for at least twice a month after the age of 5 years. So we can define enuresis only when it is occurring for at least twice a month after 5 years of the age, and the bed is usually soaking wet in enuresis. But in incontinence, there is loss of urine without normal emptying of the bladder. So here is a basic difference between enuresis and incontinence. In enuresis, there is complete evacuation of the bladder, and in incontinence, there is loss of urine without normal emptying of the bladder. By the age of 5 years, 90 to 95% children are completely continent during day, and 80 to 85% are continent at night. Mostly maximum children, they develop bladder control after the age of 4 years. Nocturnal enuresis refers to occurrence of involuntary voiding at night after the age of 5 years, means involuntary urination at night or during sleep after the age of 5 years is nocturnal enuresis, and this is the age when the child is expected to have bladder control, the age when control of micturition is expected. So nocturnal enuresis means occurrence of involuntary urination at night after the age of 5 years. Now classification of nocturnal enuresis. So enuresis can be primary or secondary. Now primary enuresis can be if it is persisting since early age, or when the child has never been dry, that is primary enuresis. But we call it secondary enuresis when bedwetting starts after the minimum period of 6 months of dryness at the night. Means after the period of 6 months of dryness at night, bedwetting starts again. That is secondary enuresis. And primary enuresis will be the child has never been dry and enuresis is persisting since the early age. Now this was primary enuresis and secondary enuresis. Now, if we have to define monosymptomatic enuresis and nocturnal enuresis, then enuresis will be called monosymptomatic when there are no symptoms of the lower urinary tract. So, enuresis is termed monosymptomatic if it is not accompanied by any lower urinary tract symptoms. And it is termed nocturnal if it is occurring only during the sleep time. So, enuresis can be primary and secondary enuresis. Primary enuresis will be child never dry, and secondary bedwetting starting after 6 months of dryness at night. Enuresis monosymptomatic and nocturnal. Monosymptomatic, no symptoms of the urinary tract. Nocturnal only during the sleep time. Now, overall 75% children with enuresis are wet only at the night time, and 25% of these children are incontinent day and night. In the first slide, we have discussed about the basic difference between enuresis and incontinence. So approximately 75% children with enuresis, they are wet but at the night time only. But 25% they are incontinent day and night. Now this distinction, that is enuresis and incontinence, this distinction was important because children with both the forms, that is enuresis and incontinence, they have abnormality of the urinary tract. Approximately 60% of children with nocturnal enuresis are males. Now this is the epidemiology of nocturnal enuresis. So enuresis is more common in the boys and less common in the girls. It is occurring most commonly in the males. 60% are the males. Family history is positive in half of the cases. In 50% cases of nocturnal enuresis, the family history will be positive. Now, if one parent, either the mother or the father, was enuretic, then each child has probability of 44% risk of development of enuresis. And if both the parents were enuretic, then there is 77% risk of developing enuresis. So family history positive in 50% cases. Maximum cases occur in the males. And if we talk about the parents, then if one parent is enuretic, either mother or the father, then there is 44% risk of development of enuresis. But if both the parents are enuretic, then there is 77% risk of development of enuresis in the child. So this was the epidemiology. Then nocturnal enuresis without overt daytime voiding symptoms affect 20% of children at 5 years of the age. It ceases spontaneously in 15% of the children every year. The frequency of enuresis among the adults is very less, that is less than 1%. And only few percent cases, 5 to 10% cases, they continue with bedwetting by the age of 10 years. But frequency of enuresis among the adults is less than 1%. Now, etiology of enuresis. Basic etiology of enuresis will be familial predisposition. Familial predisposition is most commonly seen in all the cases. Then emotional factors, psychosocial factors, they are again main cause for development of enuresis. Then delayed menstruation, again the main cause for development of enuresis. Maturational delay is the most likely cause of nocturnal enuresis. Delayed maturation may involve delayed auditory responses, delayed visual responses, delayed sphincter control, and other psychoneurological difficulties. So, delayed menstruation is the most likely cause for development of nocturnal enuresis. Then any anxiety producing episodes, especially during 2 to 5 years of the age. And this 2 to 5 years of the age, this is the most crucial, important time for development of the nocturnal bladder control. And if there are anxiety producing episodes during these years, then they will definitely affect the bladder control. So these episodes, anxiety producing episodes during 2 to 5 years of the age, they are associated with increased risk of enuresis. Then antidiuretic hormone has a circadian rhythm with increased secretion during the night, and peak secretion is between 4 to 8 a.m. Now, if there is a lack of this rhythm, or if there is an impaired response of the kidneys to antidiuretic hormone, then it can also be a possible etiology for nocturnal enuresis. Then lack of inadequate arousal is also believed to impair the vasopressin secretion and ultimately leads to polyuria. Another causes are delayed maturation of the cortical mechanisms that allow voluntary control of the micturition reflex. Then another cause is defective sleep arousal. Then next is reduced ADH hormone production at the night. Means reduced production of the antidiuretic hormone at the night time, that leads to increased urine output, that is nocturnal polyuria. Then bladder factors, lack of inhibition, reduced capacity of the bladder, overactive. Then chronic constipation. Of course, chronic constipation is again the main cause behind development of nocturnal enuresis, because in chronic constipation, the full rectum, the full bowels will put pressure on the bladder. Then organic factors such as urinary tract obstruction, obstructive uropathy, UTI, sickle cell anemia, and nephropathy. Then obstructive uropathy could be the condition in which the flow of urine is blocked. Then causes of obstructive uropathy could be bladder stones, kidney stones, bladder cancer, cancer of the prostate, colon cancer, that could lead to obstructive uropathy. Then other UTI infections, then diabetes mellitus. These are the physical causes, and these could be very rare. But still, diabetes mellitus, diabetes insipidus, chronic renal disease, children with ADHD, mentally retarded children, Down syndrome, children with deep sleep, then congenital malformations of the genitourinary tract, then chronic constipation. So these are the physical causes, but these factors are very rare in the development of nocturnal enuresis. Psychosocial factors, emotional factors, they play a very important role in development of nocturnal enuresis. Any kind of stressful home conditions like conflict between the parents, or at the homes where the parents are continuously fighting with each other. So conflict between parents, that will put a negative impact on the child, and the child will become more stressed and anxious. So stressful conditions at the home, other stressful conditions in the school like being bullying at school, or startling at school, or when the child sibling is moving to another house, to a new place, and if the child has a habit of ignoring the urge to urinate, child has poor daytime toilet habits. So these are some causes which can lead to development of enuresis. Psychological factors, they are more implicated in secondary enuresis. Psychological factors, they are more important in development for secondary enuresis. Secondary enuresis may be precipitated by acute stressful condition or traumatic experience. Means any stressful condition, any traumatic experience will immediately precipitate secondary enuresis. That's why we have said that psychological factors, they are more important in development of secondary enuresis. Then bladder irritability due to urinary tract infection or severe constipation with the full rectum impinging on the bladder and ultimately causing enuresis. Conditions causing polyuria, diabetes mellitus or diabetes insipidus. Then spina bifida, it's a neural tube defect. Then ectopic ureter, then giggle and stress incontinence. They are the other causes which are responsible in the development of nocturnal enuresis. So this was the etiology of nocturnal enuresis. Now, if the patient comes with a complaint of involuntary urination, especially at night, and the age of the child is 5 to 6 years, and the parents have said that these episodes are occurring since 2 to 3 months and have occurred for at least 2 to 3 times a month, then the probable cause will be bedwetting. Then what we will do, how can we evaluate the case of bedwetting? A careful, detailed history helps to determine whether the enuresis is primary or secondary. So our first step would be detailed, careful history to determine whether the enuresis is primary or secondary, whether any daytime symptoms are present, whether any voiding difficulty is present. So in the first step, we have to determine the type of enuresis, primary or secondary, whether any daytime symptoms present, whether any difficulty in voiding is present. If it's a case of secondary enuresis, then detailed history should be taken to rule out the acute stressful condition, because we have discussed that psychosocial factors, any traumatic experience, any acute stressful condition can lead to, it can precipitate secondary enuresis. So in cases of secondary enuresis, we will take a history to rule out that stressful condition. We will rule out polyuria and features of bladder irritability, such as increased frequency and increased urgency. Then a careful history should be obtained, especially with respect to fluid intake at night and the pattern of nocturnal enuresis. Detailed history will be obtained to determine the amount of fluid intake by the child at night and the pattern of nocturnal enuresis. Children with diabetes insipidus, diabetes mellitus, and chronic renal disease can have a higher obligatory urine output and a compensatory polydipsia. Now, we have discussed that diabetes insipidus, diabetes mellitus, these were the physical causes behind development of nocturnal enuresis. So, if we know that children with these diseases, diabetes insipidus, mellitus, or chronic renal disease, they will have a high urine output. They have polyuria and then compensatory polydipsia, that is increased thirst. The family should be asked whether the child snores loudly at night. The physician will take a detailed history from the parents, from the family members, and they will ask whether the child has a habit of snoring loudly at night. Many children with enuresis, they sleep, walk, or talk in their sleep. So this we can know from the parents only. So the family should be asked whether the child snores loudly at night, whether the child sleepwalks or talks in their sleep. Then a complete physical examination should include palpation of the abdomen and possibly rectal examination after voiding to assess the possibility of distended bladder and constipation, because we have discussed that chronic constipation is also the important cause of development of nocturnal enuresis. So rectal examination to assess the distended bladder and constipation, and physical examination should include palpation of the abdomen and rectal examination. So detailed history to rule out primary or secondary enuresis, then detailed history to rule out whether the child snores loudly at night, whether the child sleepwalks or talks in their sleep, then physical examination, palpation of bladder, rectal examination to assess possibility of distended bladder and constipation. Then children with chronic renal disease and diabetes mellitus insipidus, they have obligatory polyuria and then compensatory polydipsia. Then detailed history to rule out any bladder irritability and increased frequency and urgency. So by this way, we can evaluate enuresis. Then physical examination should also focus on the spinal anomalies, because we have discussed spinal abnormalities in the etiology of enuresis. Then, if the child has a normal urinary stream with no daytime symptoms suggestive of a voiding disorder and normal physical examination, the child does not require any other evaluation. If the urinary stream is normal, no daytime symptoms are present, then and normal physical examination, then the child does not require any other evaluation. A urine sample should be obtained after overnight fast and evaluated for specific gravity or osmolality to exclude polyuria as a cause of frequency and incontinence. Then absence of glycosuria, it should also be confirmed. Avoiding diary with frequency of urine, volume charting of urine output, and fluid intake for at least 2 days with the record of the daytime accidents, bladder symptoms, and bowel habits for at least 7 days is very useful. So basically, avoiding diary should be maintained, which should be containing frequency of urine, the volume of urine output, amount of fluid intake for at least 2 days. It should be mentioned in the diary, along with the record of the daytime accidents, bladder symptoms, and bowel habits for at least 7 days. This voiding diary is very useful, which will be containing these information. If there are no symptoms in the daytime, no daytime symptoms are present, then the physical examination and the urine analysis are normal and the urine culture is negative. Means if there are no daytime symptoms, then the physical examination, urine analysis are normal and the urine culture is also negative. A urine analysis rules out infection, proteinuria, and the glycosuria. Then additional diagnosis can be ultrasonography and MCU. MCU it's a kind of a X-ray test of the bladder. It's micturating cystourethrogram to find out if the child has any urinary reflux or black flow. So additional diagnostic feature will be ultrasonography and micturating cystourethrogram. These are limited to patients with suspected neurological or urological dysfunction. Now, here comes the management of nocturnal enuresis. So basically, general management, the physician will give advice to the parents that the parents should make efforts to remove any feeling of the guilt in the child, because after bedwetting, the child must be feeling guilty. So the parents must make efforts to remove that feeling of the guilt. They should support their child. They should encourage their child. They should reassure their child. In fact, the parents should not punish their child. They should not blame the child for bedwetting. then the best approach to treatment is to reassure the child, encourage the child, and parents that the condition is self-limited. The physician should counsel to the parents that this bedwetting condition is self-limited. It is benign, it is self-limited, and he should reassure the child as well as the parents. In fact, the parents must be counseled that they should reassure the child, encourage the child, and they should not punish or blame the child. General advice will be given to all the children with enuresis. General advice will be given to all the children having nocturnal enuresis. But we will start the active treatment after the age of 5 years and not before the age of 5 to 6 years. So general advice will be given to all the enuretic children, but the active treatment will be started after the age of 5 to 6 years and not before that. Active treatment should be avoided in younger children because enuresis is extremely common in younger children. The reason behind not starting the active treatment is that enuresis is extremely common in the younger children. That's why general advice will be given to all the children with enuresis, but the active treatment will be started after the age of 5 to 6 years. Caffeinated drinks like tea, coffee, soda should be avoided in the evening. Any kind of these drinks, these should not be given to the child, especially in the evening. Then we will bifurcate the volume of the fluids. Adequate fluid intake during day is 40% in morning. 40% fluids will be given in the morning. 40% fluid will be given in the afternoon, and only 20% fluid will be given in the evening. So adequate fluid intake during the day as 40% in the morning, 40% in the afternoon, and 20% in the evening is recommended. And caffeinated drinks like tea, coffee, and soda, they will be avoided in the evening. In addition, treatment is most likely to be effective in children who are motivated to stay dry and is less successful in children who are overweight. Means the treatment will be less successful in the children who are overweight. Treatment should be viewed as a facilitator that requires active participation by the child. Here we can take an example of a coach and an athlete. Means we want to say that the treatment of enuresis will only be successful in those children who actually want to get the treatment, who are actually actively participating. For example, a coach and an athlete. A coach can only teach an athlete when the athlete wants to learn something. So basically, children who actually want to stay dry, who are actually motivated, who actually want to get treated, the treatment will be more effective in those children only. And this treatment will require active participation by the child. Alone, the physician and the parents cannot do anything. This treatment requires active participation by the child. The first line of treatment is usually non-pharmacological, comprising of motivational therapy. The first step to treatment is motivational therapy. And motivational therapy alone is very successful in curing enuresis in about 25% patients. The child is reassured and provided emotional support. Every attempt is made to remove any feeling of the guilt. The parents should make an effort to remove every feeling of the guilt in the child. The benign nature of the disorder means the benign nature, the self-limited nature of the enuresis of this bedwetting disorder is explained to the child and the parents using diagrams if required. To explain the probable basis of the disorder means the physician must make efforts to explain the benign and self-limited nature of this bedwetting disorder to the child as well as to the parents. The child is encouraged to assume active responsibility, including keeping a dry night diary, avoiding urine before going to bed, and changing wet clothes and bedding. Means the parents should encourage the child. The child must be encouraged. He should be motivated that he has to keep the night dry. He has to avoid urine before going to sleep. Void urine before going to bed, and if he has voided urine in the bed, then wake up, change the wet clothes and as well as the bedding. So the parents must teach the child, they must encourage the child that The child should take the responsibility of keeping the night dry, and in case if he voids urine in bed, then he should wake up and change the bedding as well as the wet clothes, and also he should void urine before going to bed. Dry nights should be given with praise and encouraging words from the parents. Now, if the child has kept the dry night, then after waking up in the next morning, the parents should encourage the child. They should praise the child. They should give rewards to the child so that he could be more motivated and will keep the nights dry. Punishments and angry parental responses should be avoided. Parents should not give punishment to the child. They should not blame the child for bedwetting. Behavioral modification is encouraged to achieve good bladder and bowel habits. The child must be encouraged to have a daily bowel habit to avoid constipation. The child is encouraged both to void frequently, enough to void urgency, and daytime incontinence, and to have a daily bowel movement. Means the parents must encourage the child to void frequently, so that there is no need for urgency, and to avoid daytime incontinence, and also to have daily bowel habits to avoid constipation. Then the next treatment is alarm therapy. Now, alarm therapy, it involves use of a device to elicit means to evoke a conditional response of awakening to, to the sensation of the full bladder. Now, in this therapy there is a device which can evoke a conditional response of awakening to the sensation of the full bladder. जैसे ही बच्चे को sensation होता है that the bladder is full, he has to wake up. Conditional response of awakening to the sensation of the full bladder, and gradually the association with the bladder distension evokes micturition. Means alarm therapy में एक device होता है that evokes a conditional response of awakening to the sensation of the full bladder. जैसे ही bladder full हुआ, the child has to wake up, and gradually the association with the bladder distension will evoke micturition. The alarm device consists of small sensors. There are small sensors in this device which are attached to the child's underwear or a mat under the bed sheet, and the alarm is attached to the child's collar or placed at the bedside. अब क्या होता है इस डिवाइस के अंदर, अलार्म डिवाइस के अंदर छोटे छोटे सेंसर्स होते हैं that are attached to the child's underwear, and these sensors, they are attached over the mat under the bed sheet or to the child's underwear. और जो अलार्म होता है that is attached to the child's collar or is placed at the bedside. So when the child starts wetting the bed, the sensors are activated. These sensors were attached to the child's underwear and the alarm was placed at the bedside. When the child starts wetting the bed, these sensors get activated and the alarm rings. The child awakened to the alarm, wakes up, void in the toilet and reattach the alarm. So when the alarm rings, the child wakes up, voids in the toilet, passes urine in the toilet, and then comes back and reattach the alarm. Now in this case, the parents should attend the child each time to ensure that the child does not merely wake up to switch off the alarm. The alarm is best used after 7 years of the age. So in this therapy, the parents should also attend the child every time to make sure that the child not only wakes up to switch off the alarm. This therapy is very useful after 7 years of the age. The combination of motivational and alarm therapy is successful in up to 60 to 70% of the children. So this was the general management of the nocturnal enuresis. Now, if we talk about the homeopathic management, then few homeopathic medicines are also indicated, like creosote. In creosote, enuresis is during the first part of the sleep, from which the child is aroused with great difficulty. So basically, enuresis only during the first part of the sleep. Then dreams of urinating. Then there is sudden urge to urinate. Then next medicine is equisetum. In equisetum there is profuse urination, incontinence of urine in children with dreams of nightmares. Then next medicine is sepia. In this medicine, there is involuntary urination during the first sleep. Urine is very offensive. Bed is wet as the child goes to sleep. Then causticum. Causticum is enuresis during the first sleep at night and enuresis from slightest excitement. Causticum may enuresis from slightest excitement. Then rustox, nocturnal enuresis in boys, bed wetting in children of older age group. So this was the homeopathic management of nocturnal enuresis. With this, we complete with the topic nocturnal enuresis. Thank you.